Welcome to those of you who are joining our Buck Institute webinar. We will get started right at noon. Please have questions ready for us. Welcome to everyone who is signing on for today's webinar. This is Chris Rebelo. I'll be hosting today's event and we will be starting in just a couple minutes.
Which movie?
Hi everyone, and welcome to today's webinar focused on the COVID-19 pandemic. I'm Chris Rebelo, the Director of Communications here at the Buck Institute for Research on Aging. We have put together a great second series of webinars focused on the fight against COVID-19. Over the next 6 weeks, I'll be talking to the Director of the Centers for Disease Control and the former CEO of the Bill and Melinda Gates Foundation. You'll also hear from an infectious disease specialist who is caring for COVID-19 patients. But today is about public health. I will be talking with Dr. Matt Willis, who is the Public Health Officer in Marin County, California. Dr. Willis did both his internal medicine residency and got a master's in public health at Harvard University. He was the U.S. Public Health Service Director of Primary Care on the Navajo Nation and did research and outbreak investigations at the Center for Disease Control. Dr. Willis is also a survivor of COVID-19, We'll be talking to him about that experience as well. As always, we encourage you to be an active participant in this session. You should see a chat widget at the bottom right of your screen. Please use that feature if you'd like to pose a question for Dr. Willis. I will try to get to many of them as possible. So Matt, thank you so much for spending time with us today.
Thanks for having me.
No problem. So you're a local county health officer, but I am assuming that health officers across the country are paying attention and are aware of the large protests that are happening around the murder of George Floyd and in support of the Black Lives Matter movement. What's your take on it? Are you concerned? Advice for folks who want to get out there.
Yeah, I mean, this has been a challenge for us as public health officers to manage this confluence of the COVID-19 pandemic with a social movement. Those of us that have been doing public health recognize that racial injustice and systemic racism has been fueling so much of what we fight in public health for all our careers. And so when a movement steps forward to say that's the topic, that's what we want to change, there's a lot of reluctance on the public health side to say that shouldn't happen. But at the same time, at this particular point in time, given that the epidemic is the virus is circulating in our environment, there's a concern that these gatherings, as important as they are, might increase risk of transmission of the virus. But to get to that, the question of the purpose, I think one of the reasons that we offered a position of support actually is that we know that what the change that these protesters are seeking are also public health and maybe even a more systemic and sustainable and permanent benefit. We are seeing change in ways that I don't think we've seen before around this particular topic. In Marin County, where I live, we are the most affluent county in the state of California and have some of the longest life expectancy. But even just from my experience here working in the community clinics before I became a health officer, there was a 15-year difference. We see a 15-year difference in life expectancy between a community like Ross, which is one of our most affluent, almost all white community, wonderful community near where I live. And then, Marin City, which is a primarily African-American community just miles away, 15 years shorter life expectancy. And that's the data. Those are the numbers. And I think it's up to us to determine what attribute meaning to that and decide whether or not that's acceptable.
Do you have any advice for folks who are out there who want to get out there and have their voices heard?
Yeah, so we're really clear. We actually released, we've been releasing guidelines for different sectors to come online in the shelter in place, and we released guidelines for safe protesting. And it's essentially what we've been saying all along, which is, we know the virus is transmitted through aerosolized droplets, generally about 6 feet distance. So if we're able to practice those physical distancing principles and covering our face, especially since the protests are happening out of doors, the risk can be minimized. And so that's the first thing is, ensuring that we're covering our faces, we're practicing physical distancing. If there is someone who's, one of just the mechanics of this is if someone is screaming or yelling or singing, we know that those are obviously behaviors that go along with protesting. There's also evidence that the virus is actually more transmitted, more virus particles are emitted through those behaviors. If someone nearby is doing that and they're not wearing a mask, it's probably worth stepping away from that person or offering a general reminder that a mask would protect everyone. We're also offering testing in Marin for anyone who has participated in a protest for COVID-19. And it's important if anyone does want to get tested that it should be no sooner than 7 days after they may have participated in an event where they might have been concerned of exposure. If you get tested, before that, it's likely to be negative, and it may or may not actually represent the lack of infection because of the time it takes for the virus to assemble enough to actually be present in the nasal passages for the test. So we're offering free testing for anyone who may have participated in a protest 7 days after or after that.
Oh, that's I didn't know that timing. That's great. So let's talk about what's happening here in Northern California in Marin County. Where are we? I understand that the cases are going up, but hospitalizations are sort of staying stable. What does that tell you?
Yeah, our numbers now, we have 620 cases total across the county, 17 deaths. We've tested almost 17,000 people now. We're doing a lot more testing. 427 of our cases have recovered, and I'm one of those numbers. And we now have a new category. It's San Quentin, because we're seeing an outbreak in San Quentin prison as well. So we're counting those cases separately and there's been 15 cases in San Quentin. So that's kind of Marin County by the numbers currently. What was the second part of your question?
So where are we? Because I know that the cases keep coming up, but hospitalizations are staying stable, right?
Yes,
So
right.
Yeah,
that's important. So we are doing a lot more testing, as I said, and we're detecting a lot more cases through testing, especially in areas where we know with more targeted testing in communities that are particularly vulnerable, especially our lower income immigrant communities who have been out on the front lines as essential workers from the start, seeing high rates of positivity in those communities. What I'm looking at most carefully in terms of our decisions around opening the shelter in place is our hospitalization rates, because that's a way of controlling for bias that might be introduced. If you're doing more testing, you'll get more cases. But a proportion of people who become infected will become ill enough to be hospitalized. So it's in some ways, the hospitalization rate is a more precise indicator of actual burden in the community. And fortunately, we're a relatively small county, 260,000 total residents. We've had between 1 and 6 people in the hospital bouncing around in that range for probably the last 6 weeks. And we're still in that range, but I'm watching that number very carefully.
got it. And are the people who are being hospitalized, is there anything to say about the age group? Are they most still older adults, or what's the demographic of the folks who are having the most difficult time with COVID-19?
Absolutely, yeah. We're seeing that unfortunately, a smaller fraction of our older, so population above age 65, they make up about 25% of our population as a whole, but only about 15% of our cases. But they're about 30% of our hospitalizations, and all of our deaths, of our 17 deaths, are on people above age 65. So, our local data really mirrors what we already know about this virus, is that it really, for people of older age or people who have more serious medical conditions, are at higher risk for more serious outcomes, more likely to be hospitalized and more likely to pass.
So this is where your job, and I'm sure other health officers around the country are you can't make everybody happy. So I know here in California, there have been polls. Folks say, let's go slower. We're opening up too fast. And then you hear from people who say, what's the problem? We need to get out there. We need to open up the economy. So talk about your process. How do you decide what's safe in a community?
Yeah. Well, the shelter in place, we were among the first counties. We were part of this 6-county coalition that was really the first in the nation to do the aggressive shelter in place policy. And that was because the Bay Area was really kind of one of the first hotbeds of transmission across the United States, partly because of our relationship with the Pacific Rim and travel. Especially in the South Bay area, Santa Clara County was getting hit with really rapid acceleration in cases, exponential growth. And Dr. Sarah Cody, the health officer of Santa Clara, pulled us together, the 6 health officers of those adjacent counties, to say, we have a problem here. We need to act now, and hours matter, because she was just seeing more and more people rolling in, was concerned about her hospitals being overwhelmed. So out of that relationship and that coalition, the first shelter in place was executed. And our thinking at that time was, what sectors will we allow to remain open? And it was organized around what's essential versus what's non-essential. So essential, these are the things people need to live. So food, access to healthcare, your pharmacy, habitability. So, your tools, plumbing, certain things to keep the house going, and there was this sort of dialogue around what do we deem as essential. 6 weeks later, we shifted to a risk-based strategy for a reopening. So that's where we are now, which is the next sector to open as we move forward in 2-week intervals based on the incubation period of the virus is based on the risk of that activity. So the first things we opened were outdoor activities. And now we're moving towards more indoor activities. For example, indoor retail is going online this coming Friday. Indoor dining will come online soon thereafter. But up to this point, it's been based on an establishment of risk. And briefly, risk boils down to, if you're thinking about it from a science standpoint or a virus standpoint, it's the proximity of the encounter and the duration of the encounter. You think about the number of virus particles that one needs to ingest in order to become infected. It's about 1,000, we think. And you can get that all at once if someone coughs or sneezes on you and their face isn't covered, or you can get that over a period of time if someone is just breathing. And so when we want to make sure that those activities like salons where you have people in closer proximity, hairdressing, which obviously I haven't taken advantage of, where you're closer together for a longer period of time. Those are the businesses and the sectors that we bring online later.
Got it. So the questions are starting to come in when you talk about risk. Somebody wants to know, how do you know about the risk of making a non-essential dental appointment or a doctor's appointment? What advice do you have for folks in that regard?
Yeah, that's just coming back online now. The state has allowed the state of California is setting there's local jurisdiction rules, and then there's the state rules. The state of California is now allowing non-essential or non-urgent or emergent healthcare. And that's, we for all the reasons we do primary care in the first place, we know that mammography, colonoscopy, the regular checkup are important for long-term health. Those things have been delayed. Many people haven't obtained those sorts of services, and the harm will start to accrue the longer we wait. And so the risk has really shifted towards now that we know that the clinics are able to practice safe practices, they have the PPE they need, they're scheduling fewer appointments, so there's fewer people in the waiting room, more of the processing. I'm here next to a clinic here in Marin where they're doing the intakes actually just at the doorway, where people are out of doors because it's a nice day and there's less risk there. Those sorts of practices are making it safer for us to return to normal primary care relationships, and we're working with dentists as well.
That's great. So I just got a couple questions about schools and school openings, and I know that you had a meeting this morning. How does Dr. Willis see school opening and keeping all students, including special ed students and staff, safe? And so what can you say about what's happening with the schools here? And once again, I'm sure your counterparts across the country are dealing with this issue.
This is a huge, I mean, the uncertainty over the future in terms of just where the epidemic will be come when schools would reopen, I think it's one of the most challenging aspects in terms of planning. I just got off a call with our school superintendents and the trustees, and it's challenging to say, well, we don't really know yet how schools will open. The options are, completely distance experience if we're really just getting hit very hard. Some mix of distance learning and on-site learning, and then fully on-site. The principle that I think we're applying, and it's a little bit of an exception to what I articulated, is as a purely risk-based decision-making process. The fact that we see that schools and education are essential for our young people leads us to try and allow as much in-person learning in the classroom as we possibly can from a point of view of also ensuring safety. So I'm working very closely with the Office of Education in the state of California. A lot of the relationship has come down to the local health officers to work with their local education leaders to determine what are the strategies that are going to work within that setting, with some very general parameters that we've been given. And fortunately, here in Marin, we have she's charging forward planning, and we share. We're both very clear, I think, that our goal is to optimize children being together in classrooms as the best learning environment for them, developmentally, socially, neurodevelopmentally, et cetera. And that's the overarching principle. And then there's a variety of specific strategies that we've been working to ensure that happens.
So what might that look like? How do you keep gaggles of kids in school, going out for recess, and then keeping them safe, keeping the teachers safe, keeping the staff safe? What could that look like?
Yeah, I mean, this is really a challenge in how innovative our leaders can be, because schools will look different, and I think those that just say, well, we're only satisfied if we can do it the way we used to. That's off the table. It's we're going to have more distance between children in the classroom. Right now, CDC says 6 feet. Based on what I said about the distance that the particles float. That distance between 4 feet and 6 feet is probably a relatively low number of particles. The majority are sort of in that 3 to 4 feet, up to 4 feet. So it's possible, at each incremental step where we're able to offer a little more freedom, that corresponds to more children who can be in that same classroom together. One of the challenges I'm hearing is that if we really stick to 6 feet, it's going to be fewer kids in the classroom, and we're going to have to do 2 separate shifts. And I'm just articulating the challenges. One of the problem with separate shifts is if you have kids coming in Monday, Wednesday, Friday in cohorts of 12, then what are that Tuesday, Thursday, what are they doing on those other days? And are they also having social interactions outside of that setting where we might actually have more cohorting if we're actually able to do like 20 kids in a classroom at once, where you can do it 5 days a week. So these are some of the calculus that we're having to work out. One of the main principles is trying to limit the mixing between students. And so, we've been doing now stable cohorts of 12 kids with the same adults. And that's from an infectious disease standpoint, limits the risk of transmission beyond a certain group if any of the children are infected. So and then based on age. So, younger children, smaller cohorts. And when you get to the high school age, because the behavior can be different, they can cover their faces more reliably. They understand the principles of social distancing. We hope. I have an adolescent boy. I'm not so sure that's a safe assumption, but so we might not need to do the cohorting when it comes to high school and middle school, but for younger kids, really trying to make sure that there's that nest, that cocoon around them of just a few of a certain number of kids, and we're negotiating what that number would be.
And so then the actual details are going to be worked out over the remainder of the summer before school starts, right?
Right, and we're still waiting for guidance from California Department of Public Health in terms of, what are the rules of the game? What are the guardrails for this, and then where do we have freedom to move within that?
So I'm getting questions about testing. What's the status of testing? What's our capacity? And people are really curious about antibody testing. Where are we with that too?
Yeah, so there's 2 kinds of testing. There's the PCR testing, that's the detection of the virus itself. Usually it's a nasal swab looking for the presence of the virus in your nasal passages. That's what I say, we've had almost 17,000 people tested in Marin. And all of our cases, confirmed cases, are through that kind of testing. And that basically is positive for around a 2-week interval when you're actually actively infected. Some people remain positive for a longer period, some small fraction. Unclear whether or not that actually represents an ongoing infection where they're contagious to others. But that's the PCR test. That's I think the most important tool available to us right now is really just getting, and this has been a national story of this epidemic, has been the lack of testing capacity. We've been doing everything we can at the local level to reach our goal of 500 tests per day. That's our goal for the county, which corresponds to about 200 tests per 100,000 residents. And we're about at that goal right now. And the surge in cases we're seeing is actually partly attributable to how much success we've had in testing. The reason we need to test is that this is a virus that many people are asymptomatic, or the symptoms may be subtle, but they are infectious to others around them. And so we need to, for example, people who are in high-risk settings like skilled nursing facilities, staff, et cetera, if the risk to people they may transmit the virus to is high, we need to make sure those people are tested. So that's one of our primary strategies is that PCR testing, just to detect cases so we can do the contact investigation, isolate people, et cetera. Antibody testing, a totally separate type of testing that's looking for the presence of your body's immune response to having been infected with the virus. your body has, a library of, a memory of every disease you've ever been exposed to, for which your body mounted a response, very specific antibodies that we can look for in your system. So when you get vaccinated against measles, mumps, rubella, chickenpox, whatever it is, you have little antibodies that are specific to that particular disease. When we can, so we can look for COVID-19 antibodies through the antibody test. The two challenges with antibody testing is that we don't know what it means to have antibodies against COVID-19. So this is my situation. I was infected, recovered. I had antibody testing twice now, and it's been positive. But what science cannot tell me yet is what that means in terms of, does that confer true immunity? In other words, am I protected against being infected again with COVID-19 or not? And so I think until we answer that question, the value of antibody testing just categorically isn't clear until we actually know how to interpret the results. Secondly, the tests themselves lack accuracy in many cases, especially when there's low prevalence. A false positive rate, even a very small false positive rate, will lead to the majority of people who test positive actually being false positives if you have a low incidence in your community. So the interpretation of the results is really challenging, which is why the CDC and California Department of Public Health are not currently recommending antibody testing at the individual level to determine someone's immune status or infection status, but in some cases might recommend that it can be used for populations as a whole to determine kind of what the historical prevalence of the disease was in that population across the board, because the false positives and the false negatives sort of wash out when you're testing thousands of people at once.
How would they do that? How would they test in a larger population? What would that look like?
So there was an operation like this in Bolinas, California, a few weeks ago, where they tested 1,800 people over a 3-day period. It was a grassroots effort, partnered with UCSF, one of the research facilities here in the city, and basically did a lot of canvassing, free testing, and they did the PCR test and then the antibody test for everyone. And that's one mechanism is through sort of a research design where you're trying to get an entire community at once. Right now, where I sit in the Canal area of Santa Fe, where we're seeing lots of incidents, PCR positivity, even an outbreak really in this community. We're considering whether or not we should just try and determine how close to herd immunity, how close to that 80% or 80 to 90% of people who've been infected and rendered immune, and that's how we define herd immunity. How close are we in this community where we've seen a lot of prevalence over the last few weeks? So that's antibody testing at the community level would be a way of answering that kind of question.
And in Marin County, so you are in an area that is has a lot of dense populations of folks who are Latino, Hispanic. That's the main cause for concern right here, as far as you're concerned? Can you talk about that?
Yeah, I think it's part of the California story, really. There's an overrepresentation of people who have been out on the front lines as our essential workers in terms of our cases. In Marin County, our Latinx community makes up maybe 20% of the total, 15% of the total, but we're there, about almost 70% now of the total cases. And in the last 2 weeks, it's almost been 90% of the cases are people in that community. And it relates to exposure, leaving home every day to work, much lower, less ability to work from home. And then being reliant on daily income, working even, compelled in some ways just to make ends meet to work if you're having symptoms. And then it's less easy to isolate once you've been diagnosed, because many of these people live in units with 5 to 10 in one unit, in order to sort of pool rent so that they can afford. Obviously, the cost of housing here is high, so the risk of transmission within the household is also accelerated. So that's one of the main drivers of and the conditions, that sort of the preconditions in our community that are fueling this epidemic locally. And we're having to work fast and working really in close concert with our community-based organizations here in the Canal and other areas like this to ensure that we have the bilingual, bicultural competence to reach this community in an informed way, to offer the messaging and the support and navigate people through the choices that they're facing once they've been diagnosed.
So given that there are these hot spots within communities, do you have any sense of how this thing is going to end? Like, what's it going to take? I mean, I just read in the paper that New Zealand now says they have 0 cases. What's it going to take to really bring COVID-19 under control?
Yeah, well, it helps to be an island.
Right.
You know, and we'll see how, I mean, it'll be interesting to see if New Zealand's able to pull that off. It's a good start, but, you know, at a certain point, commerce is going to come back in, which is all, I mean, that's the story for all of us. You know, it's one thing to sort of hunker down, but that's, you know, 2 years before a vaccine, we're compelled to begin to reopen amidst a virus that's with us. So I think, you know, what we're looking at, I've just been seeing some of the modeling that's been offered for the state of California, is surges in cases. You know, these conversations that are happening now feel a lot like the conversations that were happening in early March, where people are looking at models where they're seeing a rapid rise, they're seeing hospitalization. You know, you see on your graph, you see the line that corresponds to the number of hospital beds you have, and then you see the line that corresponds to the number of cases and the people needing hospital, and they cross. So that was kind of the experience we were having in early March that led to the first shelter in place. We're seeing similar curves now being projected for in California later July and August even, which, you know, people have been talking about the fall surge. That seems to have actually in the modeling now kind of crept more into the summer. And we're, you know, I think the reason that we're still moving forward despite that is that, you know, the economic harm and other harms as the shelter in place extends starts to eclipse the potential harms of transmission. And those are challenging decisions to make in terms of a balance. But we've also had a lot of time to prepare. So our hospitals are now fully prepared for surge. We have set up alternate care sites that are ready and waiting to go. We have 50 beds that are empty right now and unstaffed, but, you know, all the equipment is there. So we've done the preparation we need. We have the testing capacity. We have the contact tracing capacity. And now it's up to us from a behavioral standpoint. I mean, I think the policies that prevented interactions was one part of this in phase 1. It's now going to be behaviors. It's going to be up to us to prevent that surge that's being anticipated in our everyday behavior. And so that's, I think, one of the most important points. And I feel discouraged when I look out and see people not wearing masks and interacting in ways, because I fear that the reopening decisions to make in terms of the shelter in place are leading to a false sense of security, or a sense that the coast is clear, it must be safe, and other behaviors are actually less vigilant, when in fact the exact opposite needs to be what we're happening. We need to be even more vigilant.
Well, that's a perfect segue. So I'm getting questions about personal activity. So somebody who lives in Solano County, they're opening gyms there. People are concerned about going back to the gyms. When you work out, you're on that treadmill, you sweat. What are the dangers? Do you think it's safe to go back to those facilities in places where they have opened up? What's your advice around those venues?
Yeah, I mean, I think as we open up more in the shelter in place, the personal choice becomes more important, because we have in some ways deprived, you know, earlier, a simple way of thinking is that there's people were sort of deprived of the choice to make, you know, to do too many things just because it was illegal outside of essential activities. By allowing those things to occur, the responsibilities will shift to the individual. So I really hope that people recognize that, you know, a gym opening up or a hair salon opening up doesn't mean it's safe to do that. It means that you are free to do that. And it's a more mature regard in some ways, but you know, certainly if someone is at risk, you know, if you're in one of those groups where you might be at increased risk, if you were infected, avoiding that, despite it being available, is probably a good idea. And if you live with someone who's in one of those risk categories, say if if your parents are living with you and they're older, that's another. But yeah, I think gyms are an example of, yes, we have processes, protocols, procedures in place. They'll be wiping the surfaces down, and those are really important. But there is a certain amount of intrinsic risk associated with some of these things that I think people need to take into account in their own decision making.
So I got a question that talks to risk. Should everybody over 75 get tested? Because like essential workers, they are in a high risk group. So what do you think about older adults getting tested?
Yeah, I mean, we're prioritizing testing for older adults. In our, we have free testing in multiple sites in Marin, and people can just go on and register to be tested, as self-registration, and they're given a time to come through. I think one of my concerns is that there would be if people are otherwise really effectively sheltering at home and have been isolated, there's not a lot of need to get tested. In fact, the act of testing might actually bring them out in ways they wouldn't have come out before. But if someone has had any potential exposures, we would recommend, especially someone in that age group, to go ahead and take advantage of the offer for testing, or they can get tested through their physician.
I have someone who is logged in there. She says she's listening for her church. What do you think about outdoor church gatherings now? Social distancing inside the sanctuary with 50 people, lots of seniors in that congregation. What advice do you have that for those folks?
Yeah, we've moved forward with the state allows now church services. Again, not one of those exceptions to the risk-based decision making. This was based partly on some of it is the sort of the First Amendment, constitutional rights to gather and worship, but also just recognizing the social value for so many to be able to practice their faith. It's not, it's one of those things that I think is not a great idea. If you're really just thinking about it from a pure infectious disease standpoint, being indoors, I mean, I think the state guidelines are that, you have to have 6 feet distance, but you can have up to 100 people inside, especially given the demographic characteristics of so many of the people who are attending church. This is not something that we have recommended here in Marin. We have allowed faith-based gatherings to occur in Marin as of last week outdoors. And that's one of the underappreciated principles of this is that there's very little, when we look at outbreaks that have occurred in the United States, many of them have been described now, and we're getting more and more information about them. Almost all of them relate to people who are together indoors, and the transmission is traced to some sort of indoor gathering. And it makes sense, because if you're breathing out into the air and you're in a well-ventilated outdoor space, the capacity for physical distancing is greater. And B, that the particles disperse so much more quickly, especially if we're covering our face. So we thought that was a safe way to approach that question of can people begin to worship together, is by doing it out of doors in Marin.
Got it. So I want to talk about process a little bit. What happens when somebody is test positive for COVID-19? Like, do you hear about it? Are there processes that kick in if somebody is diagnosed with COVID-19?
Yeah, so we've had about 620 cases, and we know all of them, each and every one, because the process is that these are laboratory confirmed cases. So laboratory is in the equation always, and we have relationships with the labs. Most of it's just a direct electronic feed from the laboratory into a database that we see. And so when a case flips positive at the lab level, we're notified as public health. And we have a team of now about 50 contact tracers. And it's their job to be looking for these, and we have a goal of reaching every single person who's been detected as a case within 24 hours and isolating them. And we're at about 80%, at that. So we're doing well, but we could do even better. So we find out about the case through the laboratory. we'll call that person, all the contact information is offered when they're tested. So we have that information to call them back. If we can't, we will go through the clinician who may have ordered the test. And then we walk them through what's, the contact investigation. So the first goal is to ensure that they are well. We'll determine what their status is, and if they need medical care, we can facilitate that. And then secondly, to ensure that they're isolated from others around them. Then we begin a process of determining who they had close contact with. And so this is a thorough interview going back for their period of infectivity. Usually it's about 2 or 3 days. If they have symptoms, we're looking at 2 or 3 days before they develop symptoms. So this is a memory game with the case to say, where were you when? Who did you have close contact with? And then we reach out to those individuals that they had close contact with to ensure that they are quarantined themselves. We use the term isolation for cases, the term quarantine for people who have been exposed. And those that are quarantined based on exposure are then tested themselves. And if any of them become positive, that cycle begins again until we've hopefully sort of interrupted a chain of transmission.
Got it. So there is one drug that shows some promise against COVID-19. It's called remdesivir. Do we have it in the county? How's that being handled?
Yeah, this is there's been scarcity in so many areas of COVID-19, whether it's testing, contact tracing app. But now the new scarcity is the treatment. There is an effective treatment. And we do have remdesivir here in Marin in an allocation. So there's a per capita allocation to counties that's coming down through the state. I think it's starting at the CDC. And for us, that was, I think, 22 doses. And so we worked with we have 3 hospitals in Marin, and we got the infectious disease specialists together and say, okay, guys, this is what we got. How do we want to allocate this? What's the most logical and fair way for patients to ensure that that need it, that they get it? And what we came up with is just a little commission that would consider cases, have a brief discussion, and no matter which hospital is in, and make a decision that this is a case based on their severity, based on other clinical symptoms. They're not so severe that they will probably pass anyway. There's different criteria that are considered, and then the drug is allocated through that process to that hospital. And we've had two patients so far since that allocation arrived where we've actually used that, and both have survived.
That's great. And there will be more coming down the pipe, one would hope, right?
Yes. And we keep submitting the requests. More is better.
Got it. So what's the situation? You mentioned this briefly, but what's the situation in nursing homes, assisted living, senior communities? What are you doing now? Are there any long-term solutions that are being considered as a way to protect this really vulnerable population, both people who live there and people who work there? What's the situation there?
Yeah, this has been one of the the other big we have the challenge of clusters at the community level in our lower income communities, and then the other, I think, just categorical hardest challenge for us is our elder care facilities, both skilled nursing facilities and residential care facilities for the elderly, of which we have about 68 total facilities like that in the county. We have a mobile testing unit that is, each day, morning and afternoon, is visiting one or another of these facilities to do testing of staff and residents. There's at any given time between 5 and 10 different facilities that have at least one staff member who has tested positive. Again, this is part of the consequences of aggressive testing, is that you see cases where they exist, and then there's a lot of follow-up, especially if that case is someone who's been working in a skilled nursing facility, because we end up often testing the all the residents, and through that process, we're able to sort of intervene as early as possible if we're seeing any transmission there, and that's been a really effective strategy. But we're needing to expand that capacity. So earlier this week, I issued an order, health officer order, requiring that those facilities actually develop the internal capacity to test both staff and residents, and that they need to test all their staff by the end of July. And the process will be testing a quarter of the staff every week in a rolling fashion, because what we found is that when we have outbreaks in these facilities, it's invariably someone among the staff who's bringing it into the facility and may not have symptoms. And so the symptom checks and temperature checks and other things we're putting in place may not be adequate or not adequate in the absence of testing. That's the kind of the current strategy is to, and then there's a lot of technical assistance, obviously, in terms of just helping them make sure that they have the proper infection control procedures, have the adequate PPE. We're supplying them all with PPE, and still unfortunately limiting visitation from the outside. I know that's a really hard thing for a lot of families that they're not able to visit, but because we have so much prevalence in the community and the vulnerability is so high, we're still preventing those kinds of visits.
So there's talk about redesigning nursing homes so that there are really private rooms, because in a lot of cases, people are sharing rooms. There are healthcare workers who go from room to room. There's talk about kind of creating pods where people are more contained, or you have the same cohort of people that are interacting. Are there plans to do that? Is that like a long range thing?
Well, we have, many versions of that now when we have cases where we're having to move people around. So they're sort of taking advantage of the architecture to sequester categories of people. And yes, we haven't, formally entered into conversations with our skilled nursing facilities around how they would actually, I think this is something that sort of a longer term lesson of COVID-19 in terms of just how we organize care for people at the end of their life or in their last years, because there's like so many things, COVID-19 has sort of pressure tested this system, and we've seen cracks all over, especially with the way that these facilities are organized and the care that they're able to offer. And so I would hope that would be just among those things that we'll be starting to do differently in the coming years based on what we've learned from this epidemic.
So I've gotten a question. Somebody says, how does getting the pneumonia shot help someone if they get infected with COVID-19? I want to include also upcoming flu season in that. So pneumonia shots, flu vaccines, helpful?
Yes.
What should people do?
Yes. That's my answer. Yeah. Now more than ever, for sure, because the last thing you need is two problems. As we know, influenza is a serious illness in itself. COVID-19, obviously, potentially fatal, especially for our older residents, who are in that recommended group for the pneumovax. Flu shot. We're going to be, and I'm hoping that, we're going to have a lot more interest in our flu shot. We every year we're out there, on the pulpit, trying to get people to come in and get their flu vaccine, because we know it's preventable. It's just, every year the strains change a little bit and you need to be revaccinated annually to be protected. We generally get, maybe 60 to 80% of people choosing to get vaccinated. But I'm hoping that this year, based on the awareness of the risks of these sort of respiratory illnesses and the risk of being co-infected with both COVID-19 and flu, that we'll have 100% vaccinations for flu and for the pneumovax.
So I want to talk about your experience with COVID-19. So how do you think you got it, and what was your experience with this thing?
Yeah. I was in. I don't know where I was infected with COVID-19. I think that's part of my story, and what I can offer is that you can't always assume that that you would recognize risk, and that it's in the environment, and we have to approach one another, as if the person you're with may be infected. Just when we're out there, this was I was diagnosed on the 20th of March. And so this was, just when we were starting to talk about physical, distancing was kind of just coming into the elbow bumps. People were laughing about not being able to shake hands anymore. It's kind of those earlier, I say early days, it's just a few months ago, but seems like a long time ago. And we were also not, if you remember, we weren't actually recommending facial coverings at that time, in public, just for routine use. So I was, part of this press conference that went along with the announcement of the shelter in place that the 6 counties came together for. Was a big event, and it was held in San Jose. So I traveled down there for the media event and announcing the shelter in place. Ironically, very packed room. One of the last events of its kind that were allowable, because just hours later we prevented gatherings like that from occurring. And it was in a hotbed area. That was an area where there was, as I said, where there was exponential growth in cases. So, and then I developed symptoms 5 days after that event. So it's possible that that's where the exposure occurred. And my symptoms were kind of classic. I got a low-grade fever, a cough, kind of a dry cough, some tightness in my chest. My wife sort of called me out on that and said, you don't look good. I said, I'm fine. And she said, you should probably get tested. And I was tested, and the next day the results came back. And then, I had about 2 or 3 days of kind of mild symptoms. I thought I would fall into that category of people with just a mild course. And then at about day 5, it really took a turn for the worse. And I ended up really kind of bedbound for almost 10 days at home, completely dependent on my wife for the only thing I was really doing was getting up to use the bathroom for that. Really felt like, a truck had kind of, run me over, and fevers every day. At one point I went to the emergency department because I was having more shortness of breath. I did have a pulse oximeter, which is the machine that measures your blood levels. And it dropped down to about 88%, which is kind of a lowish range. And went to the ED at that point to get a chest x-ray and be evaluated. Over the course of that interval, 10 days or so, I didn't need to come into the hospital. I was offered, the chance to, but because I had good support at home, I was able to recuperate at home and slowly made my way back. The whole thing took about 3 weeks before I was really back to a work, place where I could actually come in and work regularly. So it really kind of gave me a real respect for, I had underestimated this virus, and it gave me an appreciation of how severe it can be.
Are you fine now? Do you have any, because there are talks that I read a lot about folks who have this disease, that there are some folks who have lingering symptoms or may have long-term disabilities. Are you doing okay?
Yeah, I mean, I've got some funny little stuff. There's a vasculitis that goes along with, it's been described, the COVID toes. I have, my hands get blotchy sometimes, and it's clearly like a Raynaud's style sort of vasculitis. Typically, it's an immune response to the small blood vessels. There's no discomfort associated with that, but it is new, and I attribute it to that infection. And then others just, I still feel a little bit of tightness in my chest. I've been for the last week or so, I've done some little bike rides with my 10-year-old, and that's about the pace that feels right for me.
So
but I feel fortunate.
Good. I understand 2 of your kids got it, but your wife didn't get it, right? So that's another strange thing about how this disease gets transmitted, right? Right.
I mean, and if there's anyone who was massively exposed, it was my wife. But because you're transmitting the virus before you develop symptoms. But yeah, my two of my 3 kids were infected. One wasn't, and my wife wasn't, and that's one of the odd characteristics of this. And then even of my 2 kids who were infected, one was antibody negative on the test and one was positive. And then the one that had been negative, when we tested him again 2 weeks later, became positive. So just the immunologic puzzles, manifest even in our own household.
So it's great you had support. What should people do who live alone or who don't have support, who find themselves positive for COVID-19? That's a really scary situation.
It is, yeah, and I think it's one of the things that my own experience has sort of led me sort of in a more informed way to our community, which is we had been focusing on that, 5% of people that might surge into the hospitals and really looking at our ventilator capacity, ICU capacity. And, my illness sort of reminded me of the obvious, which is that under that tip of that iceberg, there's a lot of people who can be really sick, but at home. And with supports may not otherwise need to come into the hospital, but will need supports. I kept thinking if I was, one of the patients that I served in this community, how would I manage that if I say was a single mom with kids? And so we're doing a lot of work with our social services. So there's public health and then social services within the Department of Public Health or Department of Health and Human Services. And the social services people are doing a lot of work in terms of income replacement meals. We're providing meals to people into their homes who may have COVID-19, recognizing that they may not have the capacity to prepare those meals and certainly don't want them venturing out to get food. And I think it's another lesson in the need for just mutual support within our communities. People were leaving meals on our doorstep, leaving cards. That went such a long way because my wife was trying to manage 3 of us in the household and wasn't able to prepare those meals and just the neighborhood, just the way people came together to support us, I think is something we're all going to have to be kind of looking out for each other, especially if we see more cases.
Your wife must have a super immune system.
Yes, she is. We need to analyze her immune system to know what the secret is.
So I always want to highlight this because here at the Buck we're interested in keeping older adults healthy and living as long as possible. Older adults tend to have different symptoms for this disease, right? Can you talk about that?
Well, there's a lot of we've been wrestling with this challenge of how do we protect our elders in COVID-19, our older adults, and because obviously we have a principle of we don't want to be ageist in the response, and it can sound that way when we say, well, unless you're, you can come to work unless you're age 65 or older. So this is an area where I think, looking to the science and then designing the social strategy to match that. And the science is that people, above age 60, age 65, I mean, I'm 54 and, I was even concerned because, it's a continuum, like by age, the younger you are, the better you do. And it's not just, because we always know that, people who are older can do worse with X disease, whatever it might be, because the immune system maybe not as strong. There's something particular about COVID-19 beyond that makes our elders more vulnerable. And similarly, something particular in children that is almost protective. And this is I think, a unique immunologic reality that we haven't really figured out what are the correlates to that in terms of our own physiology. But unfortunately, it's true. And you can't even necessarily predict, based on the fitness level of someone who may be 65, whether or not they would have a better or worse outcome. One of our first deaths here in Marin County, in fact, our first death was a gentleman who was playing soccer on a regular basis in his mid-70s, and just had a very serious illness and it ended up passing. So I think it's we can't pretend like it's not that if you're well, if you're an active and well elder, that it's not, or a senior, that it's not, that you're not at risk. And so I think it's important when we talk about the social strategies and the shelter in place and other things, that there is a need to, I think for the next few months at least, take special measures to ensure that people are successfully isolated from those that might otherwise infect them.
I don't know if you can talk about this, but I just got a question. Can you speak about blood type in COVID-19? Because there's some studies out that show that folks with type A blood are at increased risk for having a poor outcome from this disease.
Yeah, I know. I don't know. That's an area. There's so much that's still the science is evolving so quickly. And I guess that's a a lesson to me in we've said things that we reversed. Speaking as the health as the industry, whatever, it's healthcare and science. There have been data that have suggested some things and then changed, and that's part of, I think, the transparency and the honesty that we need to be offering our communities as we move forward with this. The rules around facial covering, for example, have changed, and another example, hydroxychloroquine, a medicine that doesn't do any good at all, it turns out, and for a while it was recommended as something people should use. Ibuprofen, avoid ibuprofen. That was the message. When I was sick, it was stay away from ibuprofen. That's changed. So I think we need to take some of these when we have these early suggestions of one thing or another, really, let the dust settle a little bit around that before we get too excited about it.
Got it. So here's the final question for you from outside, but I'm sort of close to this demographic myself. As someone over 70, I did not plan on COVID-19 in my retirement plans. How long do you see us sheltering in place and practicing safety? And my question is, will I still be wearing a mask a year from now? What's the prognosis here, Doc?
A year from now, I would say that's the year is the 50-50 for me. The year is the flip a coin. I think if before a year, I would say yes. But yeah, let's hope. Let's hope.
And your final advice for folks out there, what do you want us to do?
I think it's important to not mistake reopening with safety, and the things that we've been saying all along, and maybe sort of boring as a closer, but simple but incredibly effective. Cover your face, maintain that distancing, and we can weather this together. Great.
Thank you, Matt. Thank you so very much for taking time out of what I know is a very, very busy schedule to be with us. So thanks again. And I also want to thank everyone who participated in today's webinar. Thanks for the great questions. A video of today's event will be posted on our extended session website in the near future. Our next session happens next Thursday, June 18th at 10 a.m. Pacific, 1 p.m. Eastern. I will be talking to Dr. Kevin Tracy. He's president and CEO of the Feinstein Institutes for Medical Research on Long Island in New York. The Feinstein Institutes are affiliated with Northwell Health. That's the largest healthcare provider in New York with 23 hospitals. So they were involved in that first surge. Dr. Tracy has been involved in many clinical trials focused on potential treatments for COVID-19. I'll be talking to him about that, and we'll also get some critical insights regarding what needs to happen to improve clinical trials, especially in times of crisis. So I will be back here next Thursday. I really hope you'll be here too. Keep the questions coming for our upcoming speakers. Stay safe, stay healthy. I will see you then.